So, first of all, we need to ask ourselves, why do we do root canal treatment? The answer is to treat and prevent apical periodontitis. So, we know that root canal treatment gives us a reliable outcome. However, the prognosis in terms of survival rate of endodontically treated teeth is not as good as vital teeth. Therefore, the vital pulp should be always preserved if possible. So in vital pulp therapy, we could do either direct pulp cap, partial pulpotomy, full pulpotomy, and it is always recommended to be done on teeth with reversible pulpitis with no periapical pathology, and in teeth with either mechanical pulp exposure or a recent traumatic pulp exposure. But the problem is that we cannot accurately assess whether the pulp is reversible or irreversible. So there is no any correlation between the clinical signs and symptoms with the histological status of the pulp. And the vitality test that we do in the clinic, it only gives us a yes or no answer. So there is a good systematic review by Aguilar et al. That was published in 2011, where they searched electronically and by hand of treatment of vital permanent teeth with cariously exposed pulp. And they found 23 relevant articles that they included in the systematic review, and they found that there was an overall success rate of each treatment was between 73% up to 99.5%. So as we can see, there is a very wide range of success between all of the treatments. But when we look deeper into this systematic review, we will see that most of the studies had a range of quality between 8 to 10 points out of maximum 17 points. So we can make an assumption that most of the methodology that they used in these studies was not the best, and some of them could have a risk of bias or error. So most of the methodology that was done in these studies, they had different case selection, different materials was used, different treatment protocols. For example, some studies included teeth with history of spontaneous pain and periapical reducency. And another point was 70% of the studies that was done on direct pulp cap or partial pulpotomy, they included only teeth with caries exposure, short duration of pain, or that they didn't have any pain, and they were normal response to percussion and normal radiographic appearance. While other studies, they included irreversible pulpitis, spontaneous pain, and positive to percussion. So that gives us the wide range of success between all of the studies. So let's speak histologically now. We know that in cariously exposed vital pulp, the pulp is not always completely infected. Occasionally, the inflammation was only localized to the adjacent carious lesion. For example, as you see in this histologic slide, the inflammation happens only at the site of the exposure, while the remaining pulp is normal. But clinically speaking, there is no any reliable tool to evaluate how far the inflammation has progressed into the pulp. It have been suggested that observing the degree of pulpal bleeding could give us an indication. So a severe bleeding that's difficult to stop indicates severe pulpal inflammation. And if the bleeding cannot be stopped within 10 minutes, then it suggests that the inflammation have progressed into the radicular pulp, and the treatment procedure should be modified. For example, shifting from partial pulpotomy to full pulpotomy, or from full pulpotomy to pulpectomy. So what's the procedure of direct pulp cap? It is the removal of caries and applying a pulp cap and material over the pulp exposure without the removal of the inflamed tissue underneath the caries lesion. So in the studies that was done on direct pulp capping, MTA was superior to calcium hydroxide in direct pulp capping, and the reason of that I think needs another topic to present. And in the pulpotomy studies, there was no difference of success rate between opened apex and closed apex. And in some full pulpotomy studies, they found that teeth with periapical reducency had a success rate of around 92.5%. So the critical part is the complete removal of the inflamed pulp rather than the status of the root apex. So in direct pulp capped, teeth with opened apex showed a more successful outcome than the closed apex. This is because the effect of the treatment procedure itself, because in direct pulp capping we apply the medicament at the pulp exposure site without the removal of the inflamed pulp, so it gives us a less predictable outcome. So the conclusion is, in vital permanent teeth with cariously exposed pulp, and by using a good case selection criteria, vital pulp therapy should be considered an alternative to pulpectomy, and partial pulpotomy and full pulpotomy provides a more predictable outcome than direct pulp capping, and we need for further observational studies of high quality.